East Asians. Please, Dr.
Thank you, Chairman. Good morning, everyone. I'm Ju Yong-an from Samsung Medical Center, Seoul, Korea. I'm very glad to be here, and thank you for inviting me to this wonderful meeting. These are my disclosures. Recently, European Society of Cardiology published guidelines for ACS. The antithrombotic therapy, including anticoagulation and antiplatelet therapy, is a cornerstone treatment for ACS patients. However, I would like to focus on antiplatelet therapy today due to time limit. Let's start with pre-treatment. That is, timing of loading dose of oral antiplatelet therapy. In patients with suspected STEMI, there is only one relevant RCT so far. In the Atlantic trial, there is no significant difference in MACE and bleeding between pre-hospital versus in-hospital ticagrelor strategy. However, the incidence of stent thrombosis in the pre-hospital group is significantly lower than in the in-hospital group. The median difference in the timing of loading between the two groups was 31 minutes. In patients with non-ST elevation ACS, data are also very limited. There is no benefit with the pretreatment of prasugrel in terms of ischemic events, but bleeding was increased with the pretreatment of prasugrel. In the ACOS trial, there's published in New England Journal of Medicine 2013. The median time from first loading dose to the start of coronary angiography in the pretreatment group was 4.4 hours. Moreover, pretreatment with ticagrelor was inferior to deferred prasugrel loading in the ISARVECT-5 trial. Therefore, ESC guidelines recommend a routine pretreatment of a P2Y12 inhibitor was as a class 2B for patients undergoing primary PCI and as class 3 for patients with non-ST elevation ACS. The next topic is choice of P2Y12 inhibitors in ACS. As you well know, potent P2Y12 inhibitors, prasugrel and ticagrelor, beat clopidogrel in patients with ACS in large, well-conducted randomized trial, such as Triton-TIMI-38 and Plateau. However, until very recently, there is no direct comparison between two potent P2Y12 inhibitors. In the ISARVECT-5 trial, prasugrel was compared with ticagrelor in a broad spectrum of patients with ACS. For patients with STEMI, both P2Y12 inhibitors loaded immediately after randomization, while in patients with unstable angina or non-STEMI, ticagrelor was immediately loaded after randomization, but prasugrel loading was deferred after angiography. At 12 months, the incidence of primary endpoint, defined as composite of death, MI, or stroke, was 9.3% with ticagrelor and 6.9% with prasugrel. The difference was statistically significant. Notably, definite stent thrombosis occurred less frequently in the prasugrel group compared with the ticagrelor group. There is no significant difference in terms of bleeding between the two groups. Therefore, ESC guidelines recommend prasugrel or ticagrelor in preference to clopidogrel as class 1 in patients with ACS. Clopidogrel is recommended if prasugrel and ticagrelor are unavailable, contraindicated, or cannot be tolerated. This recommendation is class 1. They also recommend if patients proceed to PCI, prasugrel is preferred to ticagrelor as class 2A. They still recommend the standard dose of prasugrel, loading dose of 60 milligram, followed by a maintenance dose of 10 milligram, and the ticagrelor, loading dose of 180 milligram, followed by a maintenance dose of 90 milligram BID. The most tough topic is duration of DAPT after ACS. The American guideline recommend DAPT of aspirin plus clopidogrel for 6 months in CCS patients and DAPT of aspirin plus P2Y12 inhibitors for 12 months in ACS patients. The ESC guidelines also recommend DAPT of aspirin plus P2Y12 inhibitor for 12 months as a default DAPT strategy after ACS. Again, clopidogrel is only recommended for a 12-month DAPT if prasugrel and ticagrelor are not available, cannot be tolerated, or are contraindicated, and may be considered in older ACS patients, typically defined as older than 70 to 80 years of age. However, various antiplatelet strategy to reduce bleeding risk after ACS have been proposed. They made some comments on this issue. The first strategy is shortening of antiplatelet therapy. They recommend in patients who are event-free after 3 to 6 months of DAPT and who are not high ischemic risk, single antiplatelet therapy, preferably with the P2Y12 receptor inhibitor, should be considered as class 2A with the level of evidence A. Let's look into the evidence. This slide summarizes recent RCTs and 3 to 6 months DAPT followed by aspirin. Of this, I would like to introduce SMART data, that is largest and was conducted by our group. This was a prospective, multi-center, randomized and open-label trial. 2,700 patients with ACS undergoing PCI were randomly assigned either to 6 months DAPT group or 12 months or longer DAPT group, standard DAPT group. The primary endpoint was 18 months MACCE, defined as a composite of all-cause death, MI, or a stroke. At 12 months, the incidence of primary endpoint, MACCE, was 4.7% in the standard DAPT group and 4.2% in the 6 months DAPT group. The non-inferiority was met. However, landmark analysis showed the strong tendency of increased incidence of MACCE in the 6 months DAPT group compared with the standard DAPT group. Especially, MI significantly increased with the short DAPT followed by aspirin. What about the trials on P2Y12 inhibitor monotherapy? Of several trials, including Twilight trial that was conducted by Dr. Roxana Maran, only TICO trial exclusively enrolled ACS patients. In this trial, 3 months DAPT followed by ticagrelor monotherapy was compared with conventional ticagrelor-based 12-month DAPT. The primary endpoint was net clinical adverse events at 12 months, defined as MACCE plus TIMI major bleeding. At 12 months, the incidence of NACE was 5.9% in the standard ticagrelor-based 12-month DAPT group and 3.9% in the ticagrelor monotherapy group. 3-month landmark analysis showed consistent findings. However, caution is needed for clopidogrel monotherapy. In the STOP-DAPT2 ACS trial, the researchers compared 1 month DAPT followed by clopidogrel monotherapy with a 12-month DAPT after Xience implantation for patients with ACS. In this trial, achievement of non-inferiority was failed, mainly due to increase in MI in the 1 month DAPT group compared with the 12-month DAPT group, while bleeding was significantly reduced by 1 month DAPT group. So taken together, short DAPT followed by ticagrelor monotherapy is promising, but aspirin or clopidogrel monotherapy needs caution in ACS. The next strategy is de-escalation of P2Y12 receptor inhibitor treatment. That is, switch from prasugrel ticagrelor to clopidogrel. This strategy may be considered as an alternative adaptive strategy to reduce bleeding risk as class 2B. The most relevant trial was thalassemia trial that was conducted by Dr. Gi-Yuk Jang, the chairman of this session. In this trial, the patient was randomly assigned either to aspirin plus clopidogrel or aspirin plus ticagrelor after 1 month common aspirin plus ticagrelor DAPT. At 12 months, the incidence of a primary endpoint, composite of CV death, MI, stroke, and bark bleeding, was 8.2% with the standard DAPT group and 4.6% in the de-escalation group. The difference was statistically significant and non-inferiority was met. In secondary analysis, there was no significant difference in the ischemic events, but the bleeding was significantly decreased with the de-escalation strategy as expected. The other option is the dose reduction. The host-reduced polytech ACS trial that was conducted by Dr. H.S. Kim, another chairperson in this session. The reduced dose of prasugrel was compared with the standard dose prasugrel, 5 mg to versus 10 mg after 1 month common aspirin plus prasugrel DAPT. At 1 year, the incidence of a primary endpoint defined as net adverse clinical events was 7.2% in the de-escalation group and 10.1% in the conventional group. The non-inferiority was achieved and the hazard ratio was significantly lower with the de-escalation group than in the conventional group. In the secondary outcome analysis, there is no significant difference in terms of ischemic events, but bleeding was significantly decreased with the de-escalation strategy. However, the incidence of major bleeding was very low in both the groups, and there was no significant difference between the two strategies. The other issue is HBR patients. They recommend in HBR patients aspirin or P2Y12 receptor inhibitor monotherapy after 1 month of DAPT may be considered as class 2B. In the master adaptive trial, patients at increased bleeding risk who underwent PCI were randomized to an abbreviated antiplatelet therapy, stopping DAPT and continuing single antiplatelet therapy versus a standard antiplatelet therapy, DAPT for 5 months if no indication for oral anticoagulation, or DAPT for 2 months if an indication for oral anticoagulation. At 11 months after randomization, the incidence of net adverse clinical events was similar between the two groups, 7.5% versus 7.7%. There is no significant difference in ischemic events, but bleeding was significantly decreased with the abbreviated antiplatelet therapy. In summary, abbreviated DAPT was non-inferior to standard DAPT regarding net NACE and MACCE, and superior regarding major bleeding. This was not a dedicated trial for ACS patients, but in the stratified analysis according to MI, the results were consistent. There are several strategies have been tested to reduce the risk of bleeding after PCI. Most strategies seems to be successful. However, 6 months DAPT followed by aspirin monotherapy, and 1 month DAPT followed by clopidogrel monotherapy needs caution. The other issue, the risk profile of enrolled patients. Of these 5 trials, only SMART-8 trial failed to non-inferiority in terms of MI. This difference may be attributable to the difference in antiplatelet strategy. However, as you can see here, the incidence of all-cause death and cardiac death was highest in the SMART-8 trial compared with the other trials. So the difference in these results might be attributable to risk profile of enrolled patients at least. In my opinion, the most important issue is the antiplatelet therapy beyond the 12 months. The ESC guidelines aspirin monotherapy as a default strategy beyond the first 12 months after ACS as class 1, but there is limited data on this issue. So far, the only one relevant trial is a host exam trial led by Professor H.S. Kim. In this trial, they enrolled more than 5,500 patients who were event-free under DAPT for 6 to 18 months. At 12 months, the incidence of the primary outcome, defined as NACE, was 5.7% with clopidogrel and 7.7% with aspirin. The difference was statistically significant. The clopidogrel was superior in ischemic composite outcome as well as bleeding outcomes. This was a very interesting results. Our group also conducting Smart Choice 3 trial. In this trial, we enrolled more than 5,000 patients being treated with the standard duration of DAPT at high risk of recurrent ischemic events after PCI with DES. We compared clopidogrel monotherapy with the aspirin monotherapy. The enrollment of patients was completed, and the results will be available in early 2025. The last topic is patients receiving OAC. The ESC guidelines, the very short duration of TAT, DAT of OAC plus clopidogrel till 1 year, and beyond 12 months, they recommend OAC monotherapy based on the results of a FIRE trial. In summary, my adoption strategy is very simple, just to follow it. So my choice of P2Y12 inhibitor is Prasugrel, unless patients have a contraindication or a caution. And my treatment strategy is Prasugrel loading for STEMI patients, typically at ER, and after confirmation of a PCI indication in non-ST elevation ACS patients, unless CAG is expected to be postponed. My default antiplatelet strategy for the 12 months after ACS is aspirin plus P2Y12 inhibitor, preferably Prasugrel. If HBR, I reduce the dose of Prasugrel or change it to clopidogrel. My default antiplatelet strategy beyond the first 12 months after ACS is aspirin monotherapy so far. However, clopidogrel is frequently used for patients with AMI, DM, or complex lesions. My default anti-PLT strategy in patients with ACS and an indication for OAC is a very short period of aspirin, followed by clopidogrel plus NOAC, and NOAC only beyond 1 year. But I still continue clopidogrel in patients undergoing very complex PCI beyond 1 year. Thank you for your attention.